Afternoon, everyone. Hopefully folks can hear me. I'd like to say thank you for joining our webinar today. My name is Eric Gray. I have spent 25 years in the military. About 16 of those were in the U.S. Army Special Forces. And after that, I went to work for the State Department, where I was the Director of Operational Medicine. Started Gray Ghost after looking across the spectrum at what the services offer and what the private sector, I believe, is missing. And so we are trying to, bridge that gap between the two different organizations for those personnel that are out, and I believe still, need the same type of response capabilities for that. With that being said, I'd like to also introduce our panel, and they'll introduce themselves. Dr. Chris Free, I've known him for quite some time. We worked on a few projects together, and I'm just glad that he is here to join with us. Also on the panelist side, you will have Mr. Josh Muller. Also work with him. He is a veteran of the military, former, and I still say, medical planning officer. He is my managing director for all things that have to do with planning. And so he will be taking a look at the questions that you will have the ability to type on your screens. And so when we get to the question and answer phase, he will be moderating that section. With that being said, Dr. Free, can you go ahead and introduce yourself to the group?
Yes, thank you, Eric. Thank you for having me on. So I'm a clinical psychologist, got my degree in 1992, and I've been working with veterans and active duty military personnel ever since. I was in the VA for 15 years as both a frontline full-time clinician, and then later as part-time at that role, and then research and such. So I've been doing research and consultation to the military community for almost 30 years. I never served in the military. As Eric will tell you, I can't shoot for shit. And I'm just another nerd with a PhD. But we've been working for quite a few years now in a variety of ways, kind of quietly outside of the military, to try to move some things along and help some of the folks from the special operations community. There's a nice little organization, a nonprofit in Houston, Texas, called the Quick Reaction Foundation, that was started up by a couple former NSW guys to help the special operations community, both Navy, Army, Marine, and Intel units. So I've been consulting and helping out with them for many years now. So my background and my efforts have really come through just direct contact with individuals, their spouses, their families. Have had many conversations with care providers in Coronado, Virginia Beach, Fort Bragg, a few other places. That's I guess just a little intro to who I am and what I've been doing.
Okay, Chris, thank you for the introduction, and I'm sure there will be plenty more questions and opportunities for folks to figure out what your background is. And so with that, we'll go ahead and get started. And what I'd like to say is, again, this webinar is for anyone who just wants to gain, an understanding of the unique set of interrelated medical, psychological, and existential difficulties termed operator syndrome faced by the SOF community. It will help SOF operators and the relevant care providers and military leaders understand how to better maximize operational and health functionings. With that, we're looking at it in two different scopes. So operational, we're talking about optimized performance and extending operator longevity for active duty service members. Health, so provision of medical and psychological treatments to enhance health, well-being, and quality of life across the lifespan. So with that, we will get started. And so Chris, tell us a little bit more about your professional background and your work with and within the special operations community.
Right. So, um, as a clinical psychologist, I've done a lot of just personal consultations um, and research. So, published a lot of research, clinical trials, epidemiological studies related to veterans' mental health, service delivery studies, historical studies, studies with biomarkers like neuroimaging and genetics. We're doing some work with the microbiome right now in Houston. So I think should I go ahead and talk a little bit about the paper that was published earlier this year?
Yeah, so
Operator syndrome?
tell us about the paper operator syndrome, you know, how it's a unique constellation of healthcare and things of that nature. And then we know that that was published in the International Journal of Psychiatry and Medicine. So yeah, give us a little more feedback on that paper, what it is
Yeah.
and what it really talks about.
Yeah. So first of all, I want to just be humble on a couple of points here. First of all, the phrase operator syndrome is not something that I or any of my co-authors on this paper came up with on our own. We may have started using it at some point, but one of the interesting things was I found a lot of care providers within Naval Special Warfare and at Fort Bragg were using this phrase, and care providers from a variety of disciplines. So I don't, just this, and I even met some operators who use this phrase. So it's kind of a colloquialism that's been used by others. We tried to take it and sort of put some parameters to it. So this study, again, my second humble point is this study is really just a very early stage type of project. I would say it's an observational study mixed with some qualitative interactions with many different people within the community. So it's just descriptive. It's not what would be considered rigorous science. So in that sense, it represents just kind of the beginning of a continuum of trying to understand what's going on with this population. So to begin with, so what is it that we're talking about? So the syndrome really starts with understanding the contextual experience of what it means to be a special operator. From my perspective, what makes special operations different from conventional forces is, well, several things, but certainly there's a selection aspect to it as to who goes into the special forces. But the thing that really stands out to me is the dose of blast wave exposure. So we know that there are two types of traumatic brain injuries. One are the concussive forces, like a blow to the head. The other is what's known as blast waves, that are invisible waves that come from a detonation and have a shearing effect on the body. They go through all of the soft tissue, lungs, brain, muscles, everything. And nobody has, I'll use the word dose, nobody has the dose of blast wave exposure in anything close to what special operation forces have. And that's as much it's more a matter of training than it is of even combat per se. Some of the other things that make special forces a little different from conventional forces is the years they have of the pounding and the wear and tear on every joint in the body. Everything from rucking with heavy packs, jumping out of airplanes, rappelling out of helicopters, and then of course the extensive combat operations that they've experienced. So back to operator syndrome. So we look at the traumatic brain injury as kind of the starting point. What's happened to your brain? What's the dose of exposures? How many concussive forces have you had? How many concussions have you had? Those kinds of things. And then from there, we see a cascade of things that we look for, starting with endocrine functioning. What's going on with testosterone, the thyroid, the estrogen levels? One of the things that I and others, my co-authors, but others around the country working with the population, is seeing very high rates of low testosterone. And one clinic that focuses on endocrine functioning in mature, like later stage career operators in Florida has reported, they just told me verbally that 96% of the operators they consult to have low testosterone. Now, we need to be careful all of us in the provider community, you need to be careful what's known as the clinician's fallacy. We all tend to see a lot of what we specialize in and not necessarily the bigger picture or the people that don't come to us. So we tend to draw conclusions based on the limited number of people that come to us. So we want to be mindful of that. But so start with low testosterone. What does that mean? If you have low testosterone and you're a 35, 40, 45-year-old man, we don't expect that. That's unusual, but we're seeing it often. If you have low testosterone, you have irritability, low motivation, low energy, you're not sleeping well, you're not functioning cognitively like you're used to, and probably you're saying to yourself, I just don't feel like the same guy I used to be. The people around you are kind of scratching their heads wondering about you as well. So that's a really important thing. That's where I always start anytime I talk to somebody is, when was the last time you had some blood labs done? And let's start with that. Over.
So Chris, just saying that thought process and what I've learned in medicine and from some of the folks that were my mentors, we're saying that around the age of 35 is when, the average male really starts to, the testosterone levels start to go down. So how does that affect, what your findings are? Is it more than?
You're saying around the age of 35 in the general male population?
Yes.
Yeah. Yeah, it's much more dramatic, much more. I mean, what you expect is that it's gradually leveling off at 35. I mean, it's starting a slow decline, but not a precipitous drop.
Okay.
What
about a person like me, in which I don't like people that much anyway, and so I'm already kind of irritable. Some of those things. Is it more pronounced than that?
Right. Well, of course, Eric, you're just a grumpy old man to begin with, so that may have nothing to do with testosterone. And yeah, so as we go through this list, there's some other things that we want to talk about, and anger and irritability are certainly one of them. There's many things that can lead to that. So it's important that's why it's important to get a blood test. It's a simple blood test. We get a blood test, we get a number, and from there, we just go from there.
Okay.
Another really common problem. Oh, sorry.
No, go ahead. Another really common
problem is sleep disturbance. Primarily insomnia. A lot of guys have nightmares. A lot of guys describe not being able to sleep well because they're hypervigilant to sounds and aspects of their environment while they're in bed. So that's a problem. And then combined with that, or in addition to that, is really high rates of obstructive sleep apnea in the guys that I've talked with. You don't expect somebody who's 35 to 45 years old and looks to be otherwise fit. It's not expected that they're going to have obstructive sleep apnea, but we routinely evaluate for that just because it's common. And of course, there's a good intervention for that with CPAP breathing machines for sleep. Another area is chronic joint pain, orthopedic problems, headaches, back, ankles, knees, headaches, migraine headaches. A lot of guys live with chronic pain. Chronic pain causes both disability and immobility, but it also affects sleep, it affects irritability, it affects mood. So, that's another thing that we want to be aware of and take a look at for each of the operators that we talk to.
Okay.
Another area is substance abuse. Go ahead, Eric. Do you have a question?
So yeah, so with all the implications of operator syndrome and from an operational perspective, like what are those? And I think you've already started talking about them, but what are those implications?
Well, you know what? I talked with somebody who was stationed overseas last year. They were on a lengthy deployment. I think it was 8 or 9 months. And toward the end of it, communicating with this fella, he said that he was really dragging. It had been a good, effective deployment, but he was worn out. And not just him, but he felt like his whole unit was worn out. And he had seen some of my work, and I guess heard one of my podcasts from last year. So he reached out to me just to kind of talk about this issue. And he's like, this really seems like an operational issue. If I'm sitting here overseas in a war zone deployment, and me and my entire unit are dragging and probably have low testosterone, and many of them did subsequently. We learned that when they returned to the U.S. and got some of that testing. So pretty clear. If you don't have motivation, if you don't have energy, if you're not sleeping, if you're not concentrating, that's some pretty clear operational implications to me.
So what about things
I want to say I'm not a commander, I'm not an officer, I'm not an operator. So want to be careful about extrapolating too much.
So with that, so what about things like awareness and mindset, lifestyle modifications, some of the things that we've actually done with some of the organizations that have reached out to us, kind of talk us through that.
Okay. Well, so I'm only part way through my list of things that make up operator syndrome, and I want to come back to that, but let me put in a quick answer to that. So I think part of optimizing performance is to have awareness, to do good, full evaluation of all systems. Endocrine system, some of these aren't actually systems, but sleep, mood, cognitive functioning, I think just simply awareness and evaluation helps people know what they're dealing with, to be mindful of some of their limitations, and then to implement solutions and strategies, which are going to be different for each of the different variables that we're talking about here. But if you kind of put them all together and come up with a comprehensive plan, there's a lot we can do to help people be more operational. So a lot of this is about mindset. A lot of this is about psychological awareness and understanding at the individual level, helping them see and manage and deal with some of the anxieties, stressors, situations that maybe are happening in their families and in their personal lives outside of the command. But also if there's psychological issues there, substance abuse. One of the things that, the next thing on my list here for operator syndrome is substance abuse. Alcohol is probably the primary one. A lot of guys are on a lot of prescription medications. So I don't want to necessarily say that's substance abuse, but being mindful of the impact of kind of a comprehensive, large scale stash of medicines coming into the body every day. Depression, PTSD, anger, I'm going to kind of lump all those together. I don't see special operators having the traditional type of PTSD that you read about, in the sense that the fear, the avoidance, the fear conditioning isn't there. A lot of operators will have occasional nightmares, and then of course they have the sleep disturbance and the anger and the depression, which overlap, symptoms overlap with other conditions. But I just don't see the fear and avoidance there in the operators I've worked with and talked to. I do see high rates of just stress reactivity. What I hear a lot is from mature operators is, I just don't understand. I'm 45 and I can't deal with the small things in my life like I used to. Yeah, right. You know what I'm talking about. I get angry. I get stressed out. I get worried. I go to the grocery store and I see somebody doing something stupid, and I turn around and I leave because I just don't want to lose control of my anger. Another one is family and marriage issues and problems. You see a divorce rate in special operations. It's probably over 100%, meaning there's a few who have had long-term marriages, and I know you're one of those rare unicorns, Eric. But many guys have 2 or 3 marriages under their belt, which is how the rate can be over 100. Probably most guys who have been married, the divorce rate is somewhere north of 80, and I've heard higher estimates of that. The life of a special operator is hard on a spouse, it's hard on a family. And so what I see often is when guys get towards the end of their career or they're out, there's a whole new challenge. If they've stayed married, suddenly they're no longer away from home all the time. Now they're home. Now there's a whole new sort of set of adjustments that have to happen within the couple as the operator is home more. We've seen a lot of problems with sexual health and intimacy, low sex drive, erectile dysfunction, obviously can be associated with low testosterone, but also some discomfort with emotional intimacy, discomfort with expressing emotions and feeling emotions, which I think is probably not an unsurprising reaction after years of operating in the special military, special operation environment. A few others, being on guard and hypervigilant. Again, that's very adaptive in a military operational context, less adaptive probably at home in civilian life, especially if it's interfering with sleep and quality of life, quality of relationships. Memory problems, concentration problems, just kind of a whole subset of cognitive impairments. And in one of our programs, we always like to evaluate the cognitive functioning, attention, memory, intellectual functioning, problem solving. That's really important. Vestibular and vision impairments. A lot of guys have balance, some trouble with balance, some trouble with vision. I don't really understand that well, but there are vestibular and vision interventions that seem to help some folks with those things. It's probably caused by blast wave exposure. Again, the shearing forces that go through the tiny, delicate muscles around the eyes, the inner ear. And then we get to the last two, which transition difficulties. Moving from military to civilian life is hard for all veterans. I don't care whether it's 4 years or 25 years of service, it's a difficult transition. It's going from one world, one culture, to another world that looks similar, has a similar language, but is very different. And there's some unique things that special operators struggle with. In part, that loss of tribe, that loss of being around the guys and the gals and the people that they served with for many years. We also have existential concerns, which include things like maybe survivor's guilt or remorse. I tend to hear more guys expressing guilt about somebody else was on the helicopter that went down and I should have been on that helicopter. Somebody else was in my spot and they caught the bullet that should have been for me. I hear a lot of that. You also have grief over dead comrades. And I just give a very personal example of a young man, an adolescent, whose father retired from the teams, talked with me at one point and mentioned that he'd lost 5 or 6 uncles throughout his adolescent life. These were men he considered to be essentially family, who were in his father's unit, and they were dead. And he lived with that fear and concern, as a child all the time, that could be his father next, but also just the grief of that loss. And then 2 other things. One is the loss of personal identity or mission. What do you do after you've been the elite of the elite for 20 plus years, or 10 years, or 8 years? What do you do after being the elite of the elite, doing critical missions of national importance? Where do you go from there? That's a difficult one. Also, this is something that the economists talk about, is a mindset that discounts the future. You've lived with death right around the corner, potentially, for a long time. Today, someday, 5 years from now, the future, tomorrow's not promised. How do you switch how do you change that mindset of discounting the future once you're no longer in service? So that's kind of a real fast overview of kind of what we are calling the operator syndrome. And just to be clear, not every operator suffers from everything on that list. Everything on that list is on a continuum. So some people may be higher on some and lower on others. One could treat each of those things individually. And that's typically what American medicine does in the civilian sector. Our view, our perspective, which is shared by many in the Navy and the Army, is that we should look at all of those things on that list together, comprehensively, holistically, with a multidisciplinary team of experts that are looking at everything, communicating with each other about what they've got, and working kind of as a team to thoughtfully address all of the problems, rather than going to a urologist for one thing, physical therapist for another, a psychologist for another, a neurologist over here, a family therapist over here, and none of them are talking to each other and communicating with each other. Over.
Okay, Chris. No, and I appreciate the breakdown and how you've looked at the different systems. You've answered some of the questions that I already had, which had to do with families and how do we, try to figure out treatments, and understanding that it's going to take everyone. And I agree with that, the fragmentation. And so from a perspective of, as you and I have talked, an individual who, a lot of us don't want to talk to people. A lot of us think that, while we can get specific help from a system, we have to travel all around to go to different locations instead of trying to just, what you and I have tested, which was bring a group of individuals and their spouses together, basically have a holistic approach using cognitive approaches, using some testing and training of things that they used to do or possibly still doing, and then figuring out how we can, help them and continue to do the jobs that they are doing. Because you're correct. When we leave that system, that teamhood, that brotherhood, it's there. But one of the things that I'm seeing really today, which is why we're doing this, is the text messages. The brothers are having issues. They don't feel like there's someone to talk to. And by the time, one of us get to them, because we kind of know how they are, unfortunately with that 22 a day, it's, they've already done it. They're in the middle of the woods and about to do it. And so we definitely need to figure out a better way, not that it's the only way, but a better way to treat some of these things.
Right. And just to, you use the word do it. Let me just put the word out there, suicide. People die by suicide, and that includes every walk of life, but we do definitely see suicides in the special operation community.
And so with that, so, what are some of the scientific limitations of your work so far? Where should we go from here?
Okay. Well, okay. So alluded to this at the beginning, but let's just talk about this. So this one publication is a description of an unusual phenomena, an unusual clinical phenomena that I and others have seen. And it's based on naturalistic observations, discussions within the community, and just, experience and seeing it. It's only one study. It's a relatively small sample as far as medical research goes. It's certainly subject to the clinician's fallacy, which is the biased perspective that all of us clinicians have on the people we see. I don't see every single operator. I only see the people that find me, or I find them. And most of the guys I've talked to have been either late career or early retirement. So I would use the term mature operators or late stage operators. I have consulted to some younger, late 20s, early 30s, and certainly of all of my co-authors and the people that we've talked to have talked with, work with younger operators. And there's probably there's a continuum. These things develop and accumulate and grow. Some of these difficulties can grow worse over time. So what do we need? We need epidemiological studies. We need longitudinal studies, of course. We need clinical studies, clinical trials of interventions. I do know that that there, without saying, revealing too much, there are efforts to do things like measure cognitive functioning at different stages of an operator's career, looking for changes, and those are efforts that have just recently started in some of the commands. So we don't know much from them right now. And then the thing we need to really get a better handle on is blast wave exposure. We have some research on concussive exposures, but a lot less on blast wave exposures. There's a few groups around the country that are now doing some really good stuff with blast wave exposures, some DOD and some VA investigators, some of whom are on this webinar today, I see. We were going to talk a little more about operational and health. Do you want to shall I quickly hit those? And then I see we got a lot of questions to get to.
Yeah, let's do that.
Okay. So from an operational perspective, what can you do? So Eric and I have done a little work on this topic together, some of which has just been thinking and planning, some of which has been applied to some actual operators in an operational situation. But I'm gonna list them here a little bit vaguely, just to go through them quickly. But we can certainly share more information. So one is awareness and mindset. Another is assessment on a regular basis and addressing those things that become identified in the course of that assessment, rather than just waiting till everything builds up and is overwhelming. Lifestyle modifications, so helping people get better sleep, more sobriety, a healthy diet, drinking lots of water, right, Eric? Drinking lots of water every day. Getting the right kind of exercise, which for many means putting less exercise, exercising smarter instead of harder all the time, pacing oneself in essence. I wear a Whoop band to measure my recovery. And I think we probably see a lot of guys who are under-recovered in their workouts and such. Treatment of any conditions that are needed. And then, of course, I think there's ways of developing targeted programs like the one that you and I and others have, and Josh and some others have developed. Okay, health. From a medical perspective, so that's operational. From a medical perspective, let's say for you, the mature operator, you're retired or you're late stage career and you realize you need some pretty significant help. It's there. It's hard to find. So let's start with DOD. The DOD has some awesome clinicians, some of the best clinicians I've ever known, met, or worked with. They've got some of the best programs. So you've got the National Intrepid Center of Excellence, NICO. You've got the Intrepid Spirit Centers, which are spread around the country. NICO's in Bethesda, next to Walter Reed. You've got some new programs that have just started up this year. There's one at Eglin Air Force Base. There's one at Fort Sam Houston that have just set themselves up to be comprehensive programs, treating essentially these kinds of problems in operators. We started a program a couple years ago in Houston at Methodist Hospital called the Synchrony Program that's intended to be a comprehensive multidisciplinary care program for the community. We have a small grant of about $500,000 a year from the Texas Veterans Commission. And of course we have the partnership with the Houston-based Quick Reaction Force, which helps fund care. So there are places, there just aren't enough of them, and there's not enough research to know exactly what is best. We don't really know what is the best way to treat traumatic brain injury. So there's standard medical treatments that are accepted practices. There's also things like hyperbaric therapy doesn't have the scientific data supporting it, but certainly anecdotally, many guys have found it to be very helpful. There's there's psychedelic treatments. There's programs all over the country that offer orthopedic surgeries for operators at cost. There's some programs in Florida and other places that help operators with their endocrine functioning. So there are treatments out there. We just need to, problem is they're spread around and difficult for guys to find and families to find. Over.
So Chris, I really appreciate the breakdown. I'm sure we have hopefully kept the audience intrigued, and we've done a little bit of education. I know I've still learned a lot, even though we talk like almost every day. Before we get to Josh and the questioning, there is one that I want to point out. And the question is, will operator syndrome have diagnostic criteria requirements and levels of severity like other DSM-5 type disorders? That's the first question. I hope it's not too long. And then secondly, will evidence-based treatment recommendations follow?
Those are excellent questions, and I think they're linked, and they kind of get to the challenge here. If you say post-traumatic stress disorder, that's a very well-defined, clear parameters disorder. It's in the DSM, the Diagnostic Manual of Psychiatry, and there are clear evidence-based practices that are recommended for it. So I'm going to say to you, I don't think we're going to get to the point where we have a clear, simple, official diagnosis of operator syndrome. I think this is probably going to be more of just a perspective and a way of approaching assessment and treatment for operators. We have developed a clinician rating scale for operator syndrome that includes each of the elements I listed, as well as sub-elements of each of those. So we're viewing that as a way of just kind of organizing the clinician's thoughts, bringing clinicians together to be able to think about each of these domains, symptom domains. If we can gather enough data with it, of course, then we can do some research to begin to validate and understand from a psychometric, rigorous research perspective, whether, kind of how to make a diagnosis, how to rate moderate, severe levels. So I would say we're way too much in the early stages of this to really be able to say, yeah, this is going to become a diagnosis. I don't think it is a diagnosis. I don't think it will become a diagnosis, but I do think it's a way of organizing and understanding the range of needs that we should be addressing. In terms of evidence-based treatments, probably not, because there's too many different problems involved here. What we really need is a multidisciplinary kitchen sink approach to address multiple symptoms with multiple evidence-based practices for the difficulties that we identify in any individual.
Okay. So Chris, again, thanks for that. What I did was basically just put the info@greatghostsolutions.com for folks that may have questions that we don't get to, but also if they want to see that questionnaire that you have developed, that I have also taken, and a few other people, they can request that there. And again, just appreciate you spending the time with us. We'll continue to, do what we do, but let's get to some of the questions that people may have, because I see some pretty good ones. So Josh, go ahead.
All right. Hi, everybody. So we have about 6 or 8 questions for time's sake, and then a couple of comments that Chris or Doc Free might want to comment on. First is from Clara. Dr. Free, are you suggesting that the blast exposures may be having effects on testosterone, or is it just an association?
I'm not expert enough to know, but I think it makes sense to me that it certainly could. I mean, something is causing low testosterone. So it's either blast wave exposure because remember, it shears through the brain, so it certainly could affect the pituitary and other glands. It could be an HPA axis cortisol response as well. I think that's probably less likely. So I don't know. I think it's an important question that we need to kind of nail down.
Okay, the next question is from Libby. Given the different presentation of PTSD in operators, do you think there might be a confluence of other invisible wounds, such as disruption of meaning-making processes or moral injury? Over.
I'm not sure I understand the meaning-making term. I don't love the concept of moral injury, partly because it sounds judgmental, partly because most of the operators I know, when the subject comes up, it bothers them. They feel like somebody else is telling them that they've been morally injured, and they don't feel like they've done anything morally wrong, oftentimes. I was at a national conference several years ago where there was a speaker speaking on moral injury, and there were probably about 350 people in this presentation in the audience, and probably about half of them were either operators themselves or spouses of operators. And I left the talk kind of early on and went out into the lobby, and pretty soon the entire lobby was full of operators and their spouses who were really turned off by the concept of moral injury. So I don't know much else to say about that.
So third question is from a gentleman named Chris Parker. Will operator syndrome have diagnostic criteria requirements and levels of severity like other DSM-5 type disorders?
So Josh, we answered that one. So it's probably just so we jumped ahead on that one. Okay. Are there any more? I have some here too, if you do not.
Let's go to the ones that you have.
Okay, so this one's from Mike, and it's asked, Dr. Free mentioned hyperthyroid as an endocrine sign. Is that, is that a co-commitment with low T, or are they found separately? If I said that right. So are they tied together?
Right, another good question. I don't know. That's outside my area of expertise. That's a research question. It's worth understanding. The best I could say is you got to get your blood labs done by somebody who knows what they're doing. That's not me, but I'll coach you on how to find that right person, and if necessary, because I want to hear them, and I want to see the labs myself, even though it's not my area of expertise, because sometimes I see things that don't look right, that aren't being diagnosed. This is another, can I segue into a tangent here, but this is an important point. There are different cutoffs for what constitutes low T or high or low variables in any of the endocrine domains. So if you're close to a line, close to a threshold, and you're told, no, you're in the normal range, it's probably a really important thing to get a second opinion or maybe even a third opinion. For example, a year ago, a guy I was talking to, I said, you sound like you have low testosterone from what you're describing in terms of your energy, your sleep, your mood, your irritability. He hadn't had his testosterone tested in years. He was only about 40 years old. He went to a doctor who told him, yeah, we did the blood labs and you're fine. Your testosterone's in the normal range. Well, his testosterone was 242. This doctor set the threshold at 240. So he was just like a smidgen above the threshold for low T, and the doctor told him he was fine. But other doctors I know set the threshold at 300. So for them, he would have been well below the threshold for low T. And subsequently, he got a second opinion, got testosterone supplementation, and he's functioning at a very different level.
Okay. And then we have two questions from Melanie, if I'm saying that correct. And one is, and I'll just separate them. How are you linking your research into clinical practice at the DoD and the VA at this time?
I am not.
Okay. We'll just leave that there. And then
I am not. Let me just say this. I talk to people at DoD and VA frequently, and I encourage them to do research. I'm certainly available to help with them, help with that research if need be. In some of both our operational program and our clinical program in Houston, we are naturalistically, capturing all of the data we collect. And once we've collected enough of it, we'll have enough objective data to say something or to understand something about the patients or the operators we've worked with in those various settings, but that's quite a ways off.
Then her second question is, if there's no barrier to integrating the understanding of operator syndrome in DoD and VA clinical care, what do you think that would look like?
Well, again, I think, best practices for me, in my opinion, would be a comprehensive, multidisciplinary evaluation and treatment approach. And the DoD is doing this. I don't know if they have enough of it, but they are doing some of it. VA, I think, is probably not doing anything like this that I know of. They probably have some TBI centers. I mean, they do have some TBI centers, but I don't think they're doing anything specific to the special operations community. In the 15 years I worked as a clinician in the VA, you know how many special forces operators I met? Maybe one. I think the answer is one. He was Force Recon in Vietnam. Now, I left the VA in 2006 before the heavy influx of global war on terror veterans were arriving at the VA. So my experience may not be representative of today. I do know that the guys and gals that I talk with who go to the VA, what many of them say is, you have to learn what services you can trust and rely on and which ones just aren't going to be appropriate for you. And I think it's just kind of a truism that most therapists, most social workers, psychologists, psychiatrists in the VA really don't have the contextual awareness of what a special forces operator does.
And Chris, I
don't really have a way of understanding them any differently from the clerical support.
And Chris, I will echo that from you to the group as a retired individual that was in the community, and that is nothing against any of those folks, because we definitely don't want to cause any type of issues. However, one, if I go in and tell the person that I was in 18 Delta, 18 Zulu, 18 whatever, they're just like, what is that? And that's okay. But then to do the explanation, then I just feel like, well, why am I here talking to you? Then for them to basically just give me their card and say, well, if you have any issues. And so it feels like, not that we are any different or any better than anyone, but I don't want to go in, as I've known people to do, and, well, I'm going to not shave. I'm going to go in freaking with, messed up clothes so this person can take me for serious, that I have something that I think is wrong with me. We never really want to admit those types of things anyway. And then when we do, it is seemed like a cookie cutter approach. And every time that I have spoken with my friends based on whatever we are terming it today, operator syndrome, everyone stops me and says, well, that's it. And so the one thing that I want to get across is, I don't think anyone here or their spouses wants to be a malingerer, because that is like the last thing that you would probably want to call anyone that I know, because they would probably, throat punch you. And I mean that in the nicest way. But two, there are certain things like, I don't consider PTSD because PTSD and what I've studied in my minor in psychology is I get hit by a bus at the corner. Every time I get to that corner, I think that bus is going to hit me. And so one of the ways to treat me is to inoculate me to that corner and buses passing by. And so I don't see the same thought process. So whatever in the end it gets called, and maybe special operations aren't the only one that would have this, because there are certainly accounts of Marines that have, traveled the globe and done tons of things, and they've gotten into various different conflict issues. But there does really need to be a difference between what you are terming PTSD and what the other thing is, operator syndrome. Over.
And I think, just to add on to that, I think, in fairness to the VA as a system and their clinicians, the percentage of special forces operators in the veteran community is what, 1%, 2% of all veterans? So it's a very small percentage, and the people in the VA don't really have the chance to become experts in this area, which is why I think some special programs are needed. Now, I will say, as I've moved around the country and talked with people and even tried to raise funding for our program in Houston, we've been met typically with many of the foundations essentially say to us, well, we don't want to support a program that's only for a small percentage. We want something that's there for everyone. And I understand that sentiment, but I think, just to emphasize again the point, that it's not about prioritizing one human over another. It's about recognizing very unique level of experiences, starting with the massive dose of blast wave exposure.
So Chris, we are at 5 minutes. Josh, do we have one more question that we can answer, or does that about cover the primary ones that you and I both were looking at?
Yep. Did you see the question from Doc Chavonis? Do you want to ask that question? You want me to ask it?
Go ahead and ask it, because I don't see it.
So he's saying fascinating and important.
Sorry. Go ahead.
Lost you.
You got muted. Go ahead.
Josh, you have to unmute.
Wow. Okay. Now can you hear me?
Yes. Go ahead.
Yes.
Okay. There does seem to be some similarities in some other high stakes professions without the self/colleague risk. How do you determine and treat the unique aspects of operator syndrome versus a high risk profession related unhealthy life? Over.
I don't know. I've never worked with professionals or sports professionals or people in other professions, but typically what you learn in one population, you can later generalize and extrapolate to similar other types of populations, adapting whatever lessons need to be adapting along the way. So, for example, a lot of what we know about concussive forces comes with work from football players, soccer players, other professional athletes. And so that's work that gets brought back to the military populations with regard to concussive forces. But no other group of people have the level of blast wave exposure that special operators have. Over.
And so, Chris, I would say this for Doc Chavonis, and thank you for joining, Doc. I would also look at, if you take the blast wave section out, but you look at policing, and you look at how they go through phase of deployment, I call it, throughout the day for every 911 call. There are some similarities that Chris and I have been discussing, and how would we be able to bring that discussion as well to policing departments as they try to figure out what is the best way. And one of those also would be, the assessment. When we, it's like the old OSS thing. Now, you're not going to be able to assess every police officer, so to speak, but just like Chris was talking about, it's how do you take the individual from the beginning to when he's on the force, maybe a couple of years, and then start doing subsequent treatments or discussions every 3 years, depending on how long they're in, and compounding that, those different endocrine functions and how they perceive, the streets or whatever it is that they're doing. But, these guys are going through the phases of a deployment every single day on every 911 call. And so we do think that there's some linkages there and some things that we can discuss. And with that, I hate to stop it because starting to get into some other things that we're very passionate about. I have 1458. I greatly appreciate, the questions that were asked by the personnel that was here. Greatly appreciate, basically everyone stayed. We only had a few people that left. And Dr. Free, really, we're homies, and I appreciate that you were able to take the time today and sit and talk with me as we continue to try to figure out what we can do to help, veterans, the population, and really get after just bringing more to the circle. And so with that, I'd like to thank everyone again. If you have any questions or anything, please feel free to reach out. And this is not about, trying to make money. This is really about trying to figure out what is the right approach for our brothers and sisters that are out there. Thank you very much.
Thank you for having me, Eric. This was a great privilege.
With that, we're out.